In the kidneys, there are a group of specialised cell types present in the afferent arteriole that collectively make up the juxtaglomerular apparatus. When blood is lost, blood pressure drops and some sodium is lost. The juxtaglomerular apparatus detects these changes and releases a hormone, renin, in response. Meanwhile, angiotensinogen, a protein, is synthesized and secreted by the liver. Renin converts angiotensinogen into another peptide, angiotensin 1. Angiotensin 1 then enters the blood, and instead of sticking around, it quickly gets converted into another molecule creatively named angiotensin 2 by another enzyme known as angiotensin converting enzyme, or more commonly known as ACE. ACE is present on the endothelial surface of all blood vessels. Because the lungs are highly vascularized, containing lots of fine capillaries, ACE is abundant in the lungs. Note, elevated ACE levels are used partly in diagnosing sarcoidosis, a rare inflammatory condition originating predominantly in the lungs. So, ACE produces angiotensin 2, which has many effects, which ultimately aim to increase blood volume or blood pressure. The main effect angiotensin 2 has is promoting the secretion of aldosterone from the adrenal cortex. Aldosterone is a steroid hormone which acts in the kidney, specifically on principal cells located in the distal convoluted tubule of the nephron. These are tubular cells which regulate how much sodium is reabsorbed into the blood and how much potassium is excreted out into the tubule to be eventually excreted in the urine. So ultimately, the channels present in the principal cell act to try and reabsorb sodium and secrete potassium. Aldosterone acts to increase the synthesis and activities of these channels, thus enhancing the reabsorption of sodium and the secretion of potassium. Reabsorbing sodium into the blood is good because water follows sodium by a ratio of 1 water molecule for every sodium ion. Another effect of angiotensin 2 is to directly constrict blood vessels. It does this by binding to a receptor on the endothelium of blood vessels called angiotensin 2 type 1 receptors, and this binding causes direct vasoconstriction, thus increasing blood pressure. Thirdly, angiotensin 2 causes increased sympathetic activity, which increases heart rate, helping to maintain cardiac output when blood volume is low. And finally, angiotensin 2 also acts to increase the secretion of antidiuretic hormone from the posterior pituitary gland, resulting in increased water reabsorption in the collecting ducts, which makes up the end part of the nephron. Antidiuretic hormone is also a vasoconstrictor, so its release also helps to maintain blood pressure in this way. So, this release of renin, subsequent release of angiotensin 2, and eventual secretion of aldosterone makes up what is known as the renin-angiotensin-aldosterone system. And once again, all the actions you see here are part of a homeostatic mechanism for increasing blood pressure and blood volume, primarily via renal sodium and water reabsorption, in situations where blood volume is low. Now we will look at how ACE inhibitors, and briefly how angiotensin receptor blockers, act on this mechanism. So, ACE inhibitors obviously work by inhibiting angiotensin converting enzyme, which has multiple downstream effects. By reducing angiotensin 2, this reduces aldosterone secretion, and thus there is less sodium reabsorption and less potassium secretion out into the tubule. It prevents the direct vasoconstricting effects of angiotensin 2, as less angiotensin 2 is present in the blood and able to bind to type 1 receptors. Note that angiotensin receptor blockers work by directly inhibiting this receptor. They also reduce heart rate by preventing the sympathetic effects of angiotensin 2. And finally, they inhibit the release of antidiuretic hormone mediated by angiotensin 2, and so this reduces water reabsorption and blood volume. ACE inhibitors reduce the volume of blood by inhibiting sodium and water retention and by causing vasodilatation. This has the overall effect of reducing blood pressure. This is ideal for treating hypertension. However, when arterial blood pressure drops, the normal physiological response is to increase heart rate in order to maintain cardiac output. This is mediated by the baroreceptor response, where baroreceptors present in the aortic arch and the carotid bodies detect a drop in blood pressure, such as that which occurs when you stand up from sitting, and they send signals to part of the brain that increases sympathetic activation, resulting in a reflex tachycardia. So you would think that giving a hypotensive drug, such as an ACE inhibitor, would cause a reflex tachycardia. However, ACE inhibitors, as I mentioned, also inhibit some sympathetic activity, which therefore partly negates this reflex tachycardia that you would normally expect with a hypotensive drug. This means ACE inhibitors are great for patients for whom a tachycardia would be potentially harmful, such as those with ischemic heart disease that may develop anginal symptoms as a result of the tachycardia. By decreasing the amount of potassium that is secreted out into the renal tubule and into the urine, the kidneys end up holding on to more potassium, and so this means that ACE inhibitors can cause a hyperkalemia. This is fundamentally the most important reason why patients that are on ACE inhibitors must have their levels of electrolytes checked regularly, as hyperkalemia can lead to potentially fatal cardiac arrhythmias. Another issue, as with any hypotensive drug, is that ACE inhibitors may lower arterial blood pressure too much, to a point where the patient becomes symptomatically hypotensive, and this typically manifests in older patients as postural hypotension, where the blood pressure drops upon standing up, possibly leading to syncopal symptoms and even falls. Another one of the most common side effects of ACE inhibitors occurs in about 10% of all those that take them. So, angiotensin converting enzyme is not only an enzyme important in the conversion of angiotensin, but it's also thought it's involved in the metabolism of a group of pro-inflammatory cytokines called bradykinins. So ACE is thought to be involved in essentially breaking down these into inactive forms. By giving ACE inhibitors and blocking this metabolism, it causes an increase in bradykinin concentrations, and it's thought that a local build-up of these in the upper respiratory tract leads to the common complaint of a persistent dry cough in those that take ACE inhibitors. This inhibition of bradykinin breakdown occurs at very low doses of ACE inhibitors, and so the development of a dry cough is not dose dependent, i.e. if someone gets a dry cough, lowering the dose of their ramipril won't help, and they generally need to be discontinued altogether. Finally, let's look at another important effect of ACE inhibitors in the kidneys. We know that when arterial blood pressure drops, the pressure in the glomerulus that is driving fluid filtration across into the renal tubule also decreases. This is detected by the juxtaglomerular apparatus, and the kidneys release renin. Renin then gets eventually turned into angiotensin II. Now, in the kidneys, angiotensin II specifically acts on the efferent arteriole, causing direct vasoconstriction. This increases the pressure within the glomerulus and maintains a good rate of glomerular filtration. ACE inhibitors inhibit the production of angiotensin II, and so ACE inhibitors indirectly cause vasodilatation of the efferent arteriole, which reduces glomerular filtration pressure and essentially GFR. This is how ACE inhibitors can cause renal failure or AKI, and why they should be avoided in most patients with renal impairment.